Hello, dear students and friends. The next topic in my series on obstetric emergencies is umbilical cord prolapse. This is a condition in which the baby or the fetus is at risk, and we all must know its management thoroughly in order to save the fetus. Umbilical cord prolapse, an obstetric emergency which is important from the fetal perspective. It is a rare event potentially associated with serious fetal and neonatal complications. The overall incidence of cord prolapse has been found to be 0.1 to 0.6%. That is nearly 1 to 6 in 1,000 deliveries. In breech presentation, this incidence is a bit higher, 1 in 100. This incidence is influenced by population characteristics and is higher when there is a greater percentage of multiple gestations. One of the consistent causes of perinatal mortality is cord prolapse, and mortality rate in these situations is nearly 1%. The reason why it may occur is that asphyxia can develop due to pressure on the cord or at times from vasospasm of the umbilical arteries. The definitions. It is basically defined in relation to the presenting part. That is the position of cord in relation to the presenting part. Two types, it could be cord prolapse, which could be occult or overt, or it could be cord presentation. In cord prolapse, the descent of the umbilical cord through the cervix alongside is occult or past is overt, the presenting part in presence of ruptured membranes. So whenever the membranes are ruptured and the cord comes down, it comes below the presenting part and out of the cervix, then it is overt cord prolapse. It could be a cord presentation in which the umbilical cord is present between the fetal presenting part and the cervix with or without the membranes intact. It does not come out of the cervix. As you can see in these pictures, it is very clear. This is an overt cord prolapse. This is a cord presentation. This could be occult cord prolapse. This is a cord prolapse in a breech presentation. Now the risk factors. It primarily occurs in two settings. First, when the presenting part does not adequately fill the pelvis because of maternal or fetal characteristics, or when some interventions are done and they dislodge the presenting part which goes up and the cord comes down. These are the various associations with both cord prolapse and presentation, general and procedure related. Generally, it may occur in multipara, babies with low birth weight less than 2.5 kg, preterm labor less than 37 weeks of gestation, fetal congenital anomalies like a large head which prevents engagement, breech presentation, malpresentations like transverse lie, oblique lie, or even an unstable lie when after 37 weeks of pregnancy, the presenting part keeps on moving. The second of twin, polyhydramnios, unengaged presenting part, and low-lying placenta. Now, when certain procedures are done, they dislodge the head, and that may cause the cord to come down, like artificial rupture of membranes with a high floating presenting part, vaginal manipulation with ruptured membranes, external cephalic version. During the procedure itself, as we try to dislodge the presenting part, the cord may come down. Internal podalic version, stabilizing induction, insertion of an intrauterine pressure transducer, or a large balloon catheter is inserted into the cervix for induction of labor. So these are the various factors associated. Anticipation. Can we anticipate that cord prolapse would occur in this particular case? Well, there is no method, but in some situations, it may occur like a non-longitudinal lie after 37 weeks, that is malpresentation, unstable lie beyond 37 weeks, preterm rupture of membranes with non-cephalic presentation. Rupture of membranes should always prompt examination by speculum or through a digital examination because this is the most commonest condition in which it occurs. Other indications of cord prolapse include abnormal fetal heart rate patterns. Now, can it be detected antenatally, that is, during pregnancy? A routine ultrasound examination is not sufficiently sensitive or specific for identification of cord presentation antenatally and should not be performed to predict the increased probability of it happening. However, in selective situations like malpresentations or breech, ultrasound screening can be considered in women who are term and considering vaginal birth. Can it be avoided or rather prevented? If we have conditions like transverse lie, oblique lie, or unstable lie, elective admission after 37 weeks of gestation can be advised. Or if they go into labor or have signs of labor and suspicion of membrane rupture, they should report immediately. Non-cephalic presentations and preterm prom patients always require inpatient care. At times, when we do artificial rupture of membranes and the presenting part is mobile or high, it should be avoided. Upward pressure on the presenting part should also be kept minimum in those women in whom a vaginal examination is being done or various obstetric interventions are being done. So do not try to push the head upwards. Rupture of membranes should be avoided if on vaginal examination you feel the cord below the presenting part. Or whenever there is a cord presentation diagnosed and the patient is in labor, do not think twice. Take her up for a cesarean section. Now, anticipation is different, and suspicion or when to suspect is different. When it has occurred, then when there's some abnormality, then you suspect cord prolapse. Like after spontaneous rupture of membranes, if risk factors are present, if there are abnormal fetal heart rate patterns, especially if there is spontaneous or artificial rupture of membranes, or if there is onset of abrupt or severe prolonged fetal bradycardia, or moderate to severe variable decelerations in a patient who had previously normal tracings. Now, in such situations, a speculum examination or at times a digital vaginal examination should be performed to rule out cord prolapse. In addition to the national guidance on fetal heart rate monitoring in labor, fetal heart rate should be auscultated after every vaginal examination in labor and after spontaneous membrane rupture. When spontaneous membranes rupture, if the fetal heart rate is normal on monitoring and there are no risk factors for cord prolapse, then a routine vaginal examination should not be performed. This shows the CTG changes associated with cord prolapse, variable deceleration, and a prolonged deceleration for more than 5 minutes. The diagnosis is made on either visualization of the cord coming out of the introitus or on palpation when the cord is seen lying ahead of the presenting part. An intrapartum diagnosis can be made by abrupt onset of severe prolonged fetal bradycardia or variable decelerations in a previous normal tracing. This diagnosis is supported by presence of risk factors and is confirmed at caesarean delivery. An ultrasound may show umbilical cord interposed between the presenting part of the fetus and the internal cervical os. At times, a cord may not be seen so clearly on an simple ultrasound, and color flow Doppler studies may be required to clarify the cord position. Sometimes by a per-abdomen scan, it may not be visible. Then in those cases, a transvaginal scan may be useful. So these are scans, transabdominal, showing color flow Doppler demonstrating the presence of umbilical cord just above the cervical canal. The differential diagnosis. Fetal heart rate changes can also be caused by various conditions, and those conditions also need to be ruled out, like sudden maternal hypotension, a tachysystole, placental abruption, uterine rupture, and vasa previa. The clinical setting helps in distinguishing these disorders from an occult cord prolapse. If there is sudden maternal hypotension, there could be fetal bradycardia, and usually hypotension occurs following neuraxial anesthesia. So, if on response to maternal IV fluids or phenylephrine or ephedrine, they resolve and normalize, then it means fetal bradycardia was due to this reason. In cases of placental abruption, uterine rupture, and vasa previa, there would be vaginal bleeding. Abruption and rupture are often painful, and occult prolapse is always painless. Tachysystole, that is excessive uterine contraction, is defined by presence of more than 5 contractions in 10 minutes over a 30-minute window period. Now, the history of giving uterotonic drugs would be self-evident, and in such situations, tocolytics can be given. Management, intrapartum management. Optimal management in these situations is prompt delivery to avoid fetal compromise and death. And in all such obstetric emergencies, the first thing to do is call for help. Call for assistance and prepare for emergency delivery. You need to call the nursing staff, anesthetists, other obstetric staff. You need to alert the operating room personnel and call pediatricians as well. Then initiate maneuvers for intrauterine resuscitation. At the same time, monitor the fetal heart rate to determine whether resuscitative interventions are effective, which impacts the urgency of delivery. Now, if the prolapse is overt, minimize manipulating an overtly prolapsed cord and avoid exposing it to the cold environment. Gently replace an overtly prolapsed cord in the vagina and keep it moist with a wet gauze. Too much handling should never be done. In such cases, perform emergency delivery by the most rapid and safe route, which is typically cesarean. Now, in some cases, selected situations, depending on the clinician's judgment, if the fetus can be delivered safely and quickly, or rather more quickly compared to a cesarean, an operative vaginal delivery can be attempted. And that is possible only if the cervix is fully dilated. The type of anesthesia, if it is neuraxial, already a catheter is in place, then continuation of that could provide adequate anesthetic level for delivery. The type of anesthesia also depends on the urgency. So this is operative vaginal delivery. Relieve pressure by pushing the baby's head up and then apply a ventouse. In all such situations, the whole team must be geared up and must know the various steps to follow. So simulation drills and team training are an essential part of management. This should be given to all care providers. It helps in facilitating communication technique, identify unit-specific barriers of emergency delivery, and it significantly lowers the time from diagnosis to delivery. In some situations, mock drills can be done after training the whole team so that they are tuned up with the various steps to follow so as to decrease the time to delivery. Now, if prolapse is occult, resuscitative maneuvers may lead to a category 2 or 1 tracing due to resolution of occult prolapse or because some other diagnosis was responsible for category 3 tracing. The decision to proceed with an urgent delivery on the basis of fetal heart tracing is to be done. If resuscitation ameliorates the concerning characteristics, then at times expectant management can also be resorted to. Intrauterine resuscitation. Basically, these are maneuvers for reducing pressure on the cord before delivery. There is no strong evidence that one is better than another, and at times combinations used prove to be more successful. So it is said that attempt all maneuvers till fetal heart rate pattern improves to category 1 or 2. First condition is manually elevate the presenting part. Now, while preparations for an emergency cesarean delivery are being made, the clinician can place a hand in the vagina and gently elevate the fetal head till it is not compressing the cord. Although effective, a prolonged period of manual elevation can be difficult for a clinician and even for the patient. That particular position can be difficult for a long time. So in this case, our fingers are put, the fetal head is elevated so that pressure on the cord is relieved. In the meantime, urgent delivery is to be done. Now, changing positions. There are two typical positions, the knee chest position and the Trendelenburg position. The knee chest position uses gravity to shift the fetus out of the pelvis. The woman's thighs should be at right angles to the bed and her chest flat on the bed. In the Trendelenburg position, the woman's hips are elevated with two pillows, and this is often combined with head down position. These two positions change the relationship between the fetus and cord and therefore elevates compression. Now, as we all know, that whenever there is a full bladder, the head fails to come down appropriately. So this is being used in this maneuver, retrofilling the bladder. Retrofilling the bladder rapidly with 500 to 700 ml of saline through a bladder catheter distends the bladder and may elevate the presenting part. Bladder filling may be useful as a temporary measure when cesarean delivery cannot be performed urgently. So this is how pressure on the cord is elevated. Giving a tocolytic. A rapidly acting tocolytic like terbutaline 250 micrograms can be given. Again, it stops uterine contractions and therefore pressure on the cord is relieved. In a report on 51 cases of cord prolapse, they used both bladder filling and tocolytic drugs and it appeared to be beneficial. There were no fetal or neonatal deaths. Now, Funic reduction, that is manipulation of the cord, putting the cord back inside. So, is it useful? After the fetal head is elevated with gentle suprapubic pressure or transvaginally or both, the cord is slipped over the widest part of the head and placed in the nuchal area. The head is then returned to its original position in the birth canal to decrease the chance of creating an oblique or transverse line. Close attention to the fetal heart rate is required. Now, this maneuver is controversial resuscitative maneuver because the procedure appeared to be associated with an increase in intrapartum asphyxia and demise in the era before continuous fetal heart rate monitoring became available. So the pros and cons of this maneuver should be evaluated and then only it may be attempted. In one subsequent small case series, 5 successful vaginal deliveries were reported 14 to 512 minutes after Funic reduction without anesthesia. Now let us consider the optimal mode of birth. Caesarean section is recommended to be the mode of delivery when vaginal birth is not imminent in order to prevent hypoxic acidosis. Category 1 caesarean section should be performed with an aim of achieving birth within 30 minutes or less if the cord prolapse is associated with suspicious or pathological fetal heart rate pattern without compromising maternal safety. Category 2 caesarean birth for women in whom fetal heart rate pattern is normal but continuous assessment is essential. If the CTG tracing becomes abnormal during that period, recategorization into category 1 birth would be essential. Discussion with the anesthetist to decide which form of anesthesia would be quick and would be easy. Regional anesthesia can be considered. Verbal consent is satisfactory for all category 1 caesarean sections, especially if the patient has been briefed of this condition before. Operative vaginal delivery at full dilatation can be accomplished quickly and safely using standard techniques and taking care to avoid impingement on the cord. So, if it can be done at full dilatation and there is no trauma or handling of the cord, then it would be easier. Breech extraction can be done in some circumstances after internal podalic version for second of kin. In all such cases, we need a competent neonatologist and paired blood samples, cord blood samples are essential. Now let us see what to do in a hospital setting. Optimal initial management in hospital settings. First is call for help. So whenever you identify the condition that cord prolapse has occurred before full dilatation, always call for help, press the emergency buzzer, and shout out for help. Preparations made for immediate birth in theatre. Manual replacement of prolapse cord is controversial. Prevent minimal handling, prevent cord compression, elevate the presenting part manually or by filling the bladder. Adopting a knee, chest, or left lateral position in the meantime is essential. And in the meantime, you can stop uterine contractions by giving tocolytics while preparing for cesarean section. Now, sometimes in some places, home births or births in community centers are advised. There are midwives, so the midwife should assess the risk of cord prolapse in all women who are requesting for home birth or in birth in centers without facilities for immediate cesarean section and at the start of labor in the community. So, when the woman is registering for a home birth, the risk of cord prolapse is assessed, and at the start of labor, also, the risk should be assessed. Women with known cord prolapse should be advised by telephone to assume the knee chest face down position while waiting for hospital transfer. So if it occurs at home, the woman is advised to take up this position. Then during emergency ambulance transfer, the knee chest position is potentially unsafe and the exaggerated Sims position, left lateral with a pillow under the hip, should be used. The patient is advised to be transferred to the next nearest consultant led unit for birth unless immediate vaginal birth is imminent as seen by vaginal examination. The presenting part should be elevated during transfer either manually or through bladder distension. Therefore, it is recommended that community midwives should carry a Foley's catheter for this purpose and equipment for fluid infusion. To prevent vasospasm, there should be minimal handling of loops of cord which are lying outside the vagina. Now, after delivery, neonatal resuscitation may be required. The baby may have low epicars and paired cord blood gases should be taken. Debriefing of the parents should always occur. They should always be told about the situation, what happened, and what maneuvers or what methods you have done. Cord prolapse at the limit of viability may be managed conservatively after discussion with the patient and the attendants about the likely outcomes. So, if the baby is unable to survive less than 24 weeks or less than 20 weeks of gestation, in that case, it may be a decision of the parents not to resuscitate the baby. And in those situations, conservative or expectant management can be opted for. So, to summarize, management of umbilical cord prolapse can be remembered with the help of a mnemonic cord. Consider the C, O, organize help, R, relieve pressure, and D, decision for birth. Consider at every vaginal examination, consider cord prolapse if there are spontaneous rupture of membranes, if there is abnormal fetal heart rate with rupture of membranes, and after membrane rupture. Organized help call for other obstetricians and midwives, anesthetists, and a perioperative team, and a neonatal team. Relieve pressure. Manually elevate the presenting part or fill the bladder. Encourage left lateral position with head down and pillow placed under left hip or knee chest position, and consider tocolysis. The decision for birth, emergency transfer to a hospital labor ward if she's in the community or at home. Assess and assist birth by quickest means. Urgency of birth is dependent on fetal heart rate and the gestational age. If cesarean section, consider if regional anesthesia is appropriate. If you have any questions, you can ask me, feel free to ask me. There are many more presentations on obstetric emergencies. Do subscribe to my channel to view them. Thank you.